hosted by SMA UK on updates on treatments on Zolgensma programme. My name's Amy Williams. I'm mum to Ollie, who has Type 1 SMA. Ollie received Zolgensma here in the UK 2.5 years ago. And I'm very excited to be joined by two clinicians with us today. So if you could please introduce yourself.
I'm Dr. Min Ong. I'm a neuromuscular pediatrician in Sheffield Children's Hospital, which is one of the infusion centres in UK for Zolgensma gene therapy, and currently chair of the National MDT for Zolgensma.
And my name's Imelda Hughes. I'm a paediatric neurologist in Manchester and work in the clinical lead for the neuromuscular team there. Manchester is also one of the infusion centres.
Well, thank you so much, ladies. It's a pleasure to have you on board with us today. So I'm going to launch straight in because there's always lots of things changing and there's going to be a lot of things to cover in this session. So before we talk about how the programme is rolled out and sort of updates on treatments, Min, perhaps as chair of the MDT, would you mind just for the benefit of anyone who's new to sort of understand how Zolgensma works and a recap on that, please?
So Zolgensma is a single-dose viral gene therapy designed to incorporate DNA, which is genetic instructions, to code for the SMN protein. And this genetic instruction is missing or jumbled or up, meaning having mutations in patients with SMA. So this DNA enters into the patient's cells so that they would be able to then produce the SMN protein. And this is a once-off intravenous, meaning into the vein infusion. This Zolgensma uses a virus that is called adeno-associated virus 9 or AAV9 to carry the DNA into the cells. And it enters into the nucleus of the cells, and which is the part of the cell that contains genetic material, and generally does not integrate into the patient's own genetic material, but sits separately and does not bind to it. So with this DNA in the cell, it would be able to instruct the cell to make the SMN protein. And then the virus will then break down and shed.
Thank you. That was very, very helpful. So, Zolgensma applied for access for some children by the National Institute of Health and Care Excellence, NICE, and the Scottish Medicines Consortiums in March 2021 for Scotland, and then had final NICE approval in July 2021. And I understand that access was further extended by NHS England. Imelda, perhaps you could outline what this has looked like in practice in terms of how the programme has been set up and managed referrals for treatment.
Yeah. So NICE have approved the treatment for patients who are pre-symptomatic and also approved for patients with Type 1 SMA. If they are aged less than 7 months, the treatment can proceed and the National MDT is notified about the treatment. If the child is aged 7 or more months, but less than 13 months, the treatment has to be approved by the National MDT. They are tasked with deciding if the child is eligible, and the criteria that NICE set for a child to be eligible was that they had more than a 70% chance of sitting, which is a very almost impossible task. But the National MDT are tasked with that. NHS England agreed that other children outside of the NICE recommendation, so those groups are included in the NICE recommendation, but NHS England said other children could be treated outside of that. They all had to have Type 1 SMA, not have a tracheostomy, not be on more than 16 hours of ventilation, and their eligibility had to be decided by the National MDT. So the National MDT was set up. This includes clinicians, consultants, physiotherapists from all of the infusion centres, SMA experts, some pharmacy experts, and initially, incident children were treated as a priority. But at that point, there were about 90 children with type 1 SMA who were on various other treatments. And so we had to look at how we would manage that. We couldn't discuss and decide on that many children at once. And so we arranged to invite referrals for children on the basis of age and weight. And we did it by what we term cohort. It was a little bit like the COVID vaccination when it first rolled out. We invited referrals, informed the regional neuromuscular centres about which children we were inviting for referral, and the national MDT would consider these. And then when those that were eligible were all treated, we would move on to the next group. So that's how it was done. And probably through the first 12 months, the majority of the children who were what we call prevalent, that is, they were the children who'd been diagnosed and were on other treatments, came through the system. By the end of the first 12 months, the majority of them.
Thank you. That's really helpful. And Mim, I don't know if you could answer this, but why has it only been limited to children with SMA type 1?
So Zolgensma is technically not limited to children with SMA type 1 because recently in July 2023, there has been NICE guidance to approve treatment also for SMA infants, meaning less than 12 months of age, who are pre-symptomatic and with up to 3 copies of SMN2 gene. And they can receive Zolgensma along with children with type 1 SMA. So there are 2 detailed NICE, which is the National Institute of Health and Clinical Excellence guidance on Zolgensma. And this is freely available, obviously, for the public to read. These documents also explain why the recommendations were made.
Great, thank you. And are you able to tell us how many children in these various groups have been treated up to now?
Yeah, I had provided a table, and we could refer to this table. So this data was from the inception of the national MDT, which was about May 2021 up until 31st of October 2023. And this was prepared for the SMA Reach 2023 meeting. So 145 patients were referred. And to date, up until now today, 157 patients have been referred. And over 100 have been infused. So about 2/3 of the referred patients have been infused. 45% of these patients are incident or pre-symptomatic patients. Not all those that were deemed eligible end up getting Zolgensma, meaning that they were eligible but not infused. And this is 17 in total, up to 31st of October 2023. And the reason behind this was a mixture of one, parental preference after counseling, clinical decision due to change in circumstance from the initial assessment, and also at that point, small numbers were waiting for infusion. Those that were not eligible, and this is a total of 22, were due to 2 having had SMA type 2, 1 having high AAV9 antibodies, which is a contraindication to Zolgensma therapy, following discussion of their eligibility, and 1 that was referred had a weight greater than 21 kilograms, which is above the weight limit in the guidance for prescription. However, the majority of those in the not eligible column were actually of patients where parents withdrew their consent after referral. So some were even before their case was discussed, and but the majority was after the family had discussions with the infusion center. 10 of the referrals were actually of 5 patients, so some patients were referred twice. And in the last year, 70% of the referrals are of incident and pre-symptomatic patients versus, the total number of 44% over the 3 years.
A lot of numbers in there, and significant number of children that have been treated or not treated for various reasons. So thank you very much for explaining that, Min. We know that during this time there was a pause in the programme as there were some concerns. Imelda, would you mind telling us a bit about this and your reflections on your experience?
Yes, there was a pause because a number of children had very severe liver problems. As you all know, very many children will have disturbance of liver function. It is probably the commonest adverse effect of this treatment. Most of these children don't have any symptoms, so they're well, but on blood tests their liver function is disturbed. However, 2 children worldwide have died of acute liver failure, and in the UK there have been several children who had very severe liver disturbance. If there is a quite marked liver disturbance, the first treatment that's done is the dose of prednisolone, which is routinely given, is doubled. If that doesn't help, steroids can be given intravenously, and then there are other drugs to suppress immune response, which may need to be given, and a number of children needed to be given other immunosuppressive treatments and required inpatient hospital treatment for their liver disturbance. Fortunately, they did all recover, but it was at this point that there was a pause in the programme for those outside of the NICE recommendation. So it was only for the children outside of the NICE recommendation that it was paused, not for those within the NICE recommendation. The situation was investigated, and it was felt that there were no new safety signals, and so the pause was lifted.
Thank you for explaining that. It's a really, really important point to cover because, obviously there's huge risks that go with such a medicine as this. So thank you, Imelda. So we're aware, and this is something that I see a lot within the SMA community that I'm part of, that families whose children have had treatment have had different experiences at different infusion centres. And can you tell us a bit more about the different decisions and what kind of impact this has?
There may be more differences perceived than there actually are, because certainly all of the children outside of the NICE recommendation are discussed at the National MDT, and in fact, most of the children under 7 months are also discussed. One of the biggest problems I think really facing us now is that children are diagnosed because of symptoms, and very sadly, most of the children we see, most of the new babies we see with SMA Type 1 are very severely affected. And it became clear to the infusion centres very, very quickly after we started treating that to withstand this treatment, babies really needed to be in the best possible health that they could be. And so for that reason, and perhaps increasingly over time, advice is given to optimize the child's health, to assess the nutrition, supplement nutrition if that's needed, to assess the respiratory state and support that if that's needed before treatment is given. We know that there are other treatments available. All of these treatments are effective, and none of them is clearly any more effective than any of the others. So that's why sometimes there's a perception of delay in treatment, but it is actually to optimize the child's chance of doing well with gene therapy. Because if their health is not optimized, there's certainly a very big risk that they will not do the best they might. And treatment is not delayed. There's a question about vaccination. Treatment is not delayed for vaccination. If treatment is being delayed to optimize the child's health, part of that is getting vaccines. And, treatment may be delayed for other reasons. For example, in newborn babies, they may have AAV9 antibodies. And so treatment has to be delayed until those wane. And so that's an opportunity to do things like get vaccinations, because the steroids required for gene therapy mean that the vaccination program has to be interrupted. And also, for live vaccinations and for any vaccinations, they really shouldn't be given probably within a month before or after gene therapy. So it's really, these things are very, very carefully considered, and they are generally discussed at the National MDT. And there may be perceived differences. And of course, in hospital sort of policies and approaches and ways of admission, there may be local differences that are dictated by separate hospital policies. But I don't think there is any very clear differences between how between the medical management of these babies and children.
Thank you. Yeah, I think a really strong thing there to note is having children in there, as strong as possible as they can be to receive this treatment. And if ever there was a case for newborn screening, I think that's there, but that is a completely different webinar, so I will not go down that tangent. So last year, SMA UK published information on some clinical trials where they administer Zolgensma directly into the spinal fluid. Will this be a safer way for older children to receive it? And Mim, perhaps you can tell us a bit more about this approach.
Yeah, so there have been trials on intrathecal, meaning into the spinal fluid, Zolgensma. So the first one is the STRONG study, and they have published their results in March 2023. This was a phase 1 study, which means that it is mainly to look at safety, but they also do look at efficacy, and it ran for a period of time, and it was on 3 varying doses of Zolgensma into the spinal space. They had 2 cohorts of patients, so those between 6 months to 24 months, and then those who are greater than 24 months old. And it was for patients with type 2 and 3 SMA. They managed to enroll 32 patients, but the study had to be terminated early following an initial pause during the phase of recruitment due to findings of potential dorsal root ganglia, so a part of the spinal cord showing changes in non-human models that received Zolgensma. Although it was not conclusive, the investigators decided to terminate the study following that pause. They did, however, publish their evidence showing that there is no efficacy in patients aged 6 to 24 months in this cohort, but those between the 24 months to 60 months, the older patients, there was a change in the functional motor scores, and this was statistically significant to the natural history cohort. However, they also tried to look to see whether they would meet an endpoint of achieving ability to walk, and for this cohort, it did not achieve that. They felt that intrathecal, so into spinal space, Zolgensma was safe and well tolerated. And because this is only a phase 1 study and it was terminated early, we do not currently have enough data or evidence to show for sure if this is a safe way to give Zolgensma to older, heavier children. So there is a need for bigger trials for the intrathecal delivery of Zolgensma and comparing it to intravenous way of giving Zolgensma, which we now do. Novartis is currently running a a trial, the STEER trial, and this is a bigger trial, so it is a phase 3 trial. So it has met many more patients, 125 patients, and they are looking at a 15-month trial duration period and potentially maybe looking for longer efficacy as well. They are looking at how effective this drug is, but also collecting safety data. In this trial, the patients are actually randomized compared to the previous trial where all the patients were given intrathecal Zolgensma. So meaning that some patients will initially get the Zolgensma drug, but some patients will be randomized to a placebo or a sham drug given also intrathecally, but they plan to cross over later on so that all patients will receive Zolgensma intrathecally. The results of this trial is still not out, so it's awaited. I hope that answers your question.
Yes, thank you. That's a lot of detail. Thank you. And so looking forward, how do you see this program developing further?
I think we all hope that newborn screening will become, that the SMA will become part of the newborn screening program in the UK. And that will bring a change. From other countries that are doing newborn screening, it's clear that at the time of diagnosis, particularly children with 2 copies of SMN2, a number of them are already symptomatic, about 40%. So the outcome will not be just the same as the outcome of clinical trials, because in clinical trials, the pre-symptomatic patients were purely pre-symptomatic. But without doubt, the outcome will be better than we're currently seeing. Because although these children may be symptomatic to a paediatric neurologist, they may well not have come to attention. And I think, as many families know, from the time they first have worries until they actually receive a diagnosis can be quite a long period. So I think that will be a change when it comes. And I think we would all very much relish the potential for treating children much earlier than we currently are. Until such a time comes, we continue to have our meetings, our discussions of patients, and offer treatments, and also review results to date. And there has been a paper published on the outcomes of the first 99 patients in the UK who were treated. So, we continue to discuss and treat, and always the discussion is about what is in the best interests of the child, and whether the risks of this treatment outweigh the benefits, or whether the benefits of the treatment potentially outweigh risks. And that really is the bottom line that dictates the decision-making process. I suppose the only other thing I would say is that when this treatment first started, the only other treatment available was nusinersen, and since for the first approximately 12 months, but then risdiplam became available, and I think that has also changed what might be recommended for some of these infants as well, at least as an initial treatment.
Certainly, yes. I think that just leads me on to my last question. So it's because it's something that a lot of families are always asking about. What are your views in your professional capacity about combining Zolgensma with another treatment for children who have symptoms, such as nusinersen and risdiplam?
So to answer this question better, we need to know that the natural history of denervation, meaning the loss of nerve capacity in SMA, is one that begins very early on in life and around birth, potentially before birth even. And the decrease in function is exponential over time, particularly in the type 1 SMA patients. And it appears that the SMN protein and the SMN1 gene are particularly important during the development of the motor neurons in early life, and potentially less so important later on in life. And it is thought that once a motor neuron degenerates, there would be very little regeneration and also very little reversibility potential. The SMN protein and gene also, we know increasingly now, plays other roles in other body and cell functions that are not limited to nerves. And unfortunately, understanding in this is still quite limited. So Zolgensma is thought to be able to produce a robust SMN expression and potentially for a long, long time. But there is a potential that this will be overexpressed, and also overexpressed later on in life when potentially it may not be so important. So there are also potential toxicity with added therapies that will increase the SMN protein production, and this has been identified in some animal models, and we need to still know or get more information about it to understand it better. So in clinical trials, there are trials with nusinersen given post-Zolgensma, and this is through the RESPOND trial, which is a phase 4 trial. So it's to assess safety and efficacy of nusinersen in infants and children up to 3 years of age who has SMA and had been given Zolgensma before. They had shown an interim result in one of the SMA conference to show that it has resulted in increased motor function in most participants, but the study conclusion and expected completion is not until October 2025. In addition to that, Biogen, the company that makes nusinersen, is also running another drug trial on an antisense oligonucleotide, which is a similar type of drug to nusinersen. It is the BIIB115 trial, where the drug is given intrathecally like nusinersen, but the doses are anticipated to be only given every year. So this is currently running and open for recruitment internationally. And this is for children who have had Zolgensma in the past and are deemed to not have maximal response post-Zolgensma. There are also trials of risdiplam following gene therapy, and the initial one was Jewelfish trial, which not only looked at children who received Zolgensma previously, but also other drugs. And this is an ongoing study, and the study completion date is expected to be in December 2024. I also know of 2 trials that Roche is running. So the HINELEA 1 and 2 trial, which is currently not open, but it is an open label single arm trial, so meaning giving one drug, which is risdiplam, multi-center study, looking at whether risdiplam post Zolgensma may be useful in children with 2 copies of SMN2, and either they have previously tried Zolgensma or previously tried Zolgensma and experienced a plateau or decline in function. There are currently, not to my knowledge, any studies of other drug therapies like myostatin inhibitors post-Zolgensma. However, in conclusion, I think there's currently no convincing evidence published to show the superiority of combination therapy with 2 more disease-modifying therapies in SMA. So we cannot currently recommend combination treatment at the moment. Evidence needs to be collected in a controlled clinical trial setting, and this is with head-to-head comparison. I also know that there is a European consensus statement that is due out soon, and we have discussed this at the SMA REACH meetings, and will potentially look into a UK consensus statement on this.
Brilliant. Well, with no more questions from me and all that excellent information that you both share with us, I just want to say thank you so much for your time, Imelda and Min, and thank you to SMA UK for putting this webinar out there for parents to watch.
Thank you. Thanks for the invitation.